Thank you for inviting me to speak at your conference. I'm sorry I can't be with you, and I do hope to visit Ukraine one day. It is not a country I've yet visited. My thoughts are with you at this very difficult time for Ukraine, and I hope peace prevails. We're hearing a lot about the challenges you face in the news. And of course, I hope your stroke services thrive and stroke patients continue to get better outcomes as we seek to improve care across Europe for stroke patients. And in that regard, I'm a strong supporter of the European Stroke Organization, and we hope that will help you and other Eastern European colleagues. So I've been asked to talk about neuroprotection in acute stroke, and specifically about the trial data of Edaravon. So I'll spend the first half of my talk just some general observations about neuroprotection, and then look specifically at the data we have Edaravon, and of which I was involved in one of the phase 2 trials when I worked in Newcastle about 10 years ago. So I've been involved in stroke care for 30 years now, and we really have seen a transformation in the outcomes for stroke patients and the treatments we can offer to stroke. But when I was a medical student and I just qualified, it was generally thought that stroke was untreatable. And I put in a quote there from the Oxford textbook of medicine in 1983 when I was training to be a general physician. And this is Charles Warlow, a very eminent stroke neurologist, who summarized at the time that there was little that medical treatment could do to alter the outcome from stroke, and fibrinolytic drugs and anticoagulation should not be used. And of course, things have changed very dramatically since then. By the time I established a stroke unit in 1993, we did have data that we could reduce mortality from stroke from the Peter Langhor meta-analysis of the stroke unit trials. So that was the first solid piece of evidence we had about the value of medical care for improving stroke. And then since then, this table summarizes the various treatments available for stroke that we seek to apply and the proportion of patients who we can apply them to. So nearly all patients benefit from going to organized stroke care in a stroke unit. And if you do that, for every 100 patients that go through, 5 will avoid death or dependency that would otherwise have happened. Dependency being significant disability, they need care from someone else. We now have thrombolysis, both in the 3-hour window and 4.5-hour window. In a country like the UK, we seek to treat 20% of patients, most of those in the 0 to 3-hour window, and we certainly achieved that in my hospital service, although the average is still around 11% in the UK, and it varies a lot across Europe. A major advance has been thrombectomy, very powerful treatment for those patients who have stroke due to large vessel occlusion, and our modeling suggests around 10% of patients presenting to hospital, at least in the UK, are eligible for thrombectomy. That is, they present early enough and with a favorable imaging profile with large vessel occlusion. And then we have early prevention with aspirin, interventions to prevent pulmonary embolism, intermittent pneumatic compression sleeves, and hemicraniectomy for people who have malignant MCA infarction. So if we bundle all these together, we can now make a major impact on outcome for over 10% of the patients we admit to our unit. And for the rest, we're helping provide more rapid recovery and return to the community. So one treatment that is not in that table, which we in the 1990s would have thought would be by now, is neuroprotection. And we've known for a long time in animal models about the presence of the ischemic penumbra. That is an area of tissue when you have a blocked artery that has reduced blood flow but is salvageable if blood flow can be restored and you can protect those neurons from ischemia. And we also know from imaging, both with MR imaging, with diffusion perfusion imaging, and with CT perfusion imaging, we can demonstrate the presence of the penumbra in humans as well with large vessel occlusion stroke. And on the right-hand side of the slide shows the ischemic cascade that is mobilized, which we can intervene at a number of points. And yet, despite this clear therapeutic target and us being able to show through thrombolysis and thrombectomy that if you restore blood flow to the penumbra, we do improve outcome. We've had multiple failed trials. This is from a review of, actually it's from the previous author, Buchan, of the number of trials that were undertaken in over 12,000 acute stroke patients in the last 25 years. And all of them either failed or showed very marginal benefit. And the vast majority were neutral, and some actually showed worse outcomes. And this has been tried with translation of positive results in animal models with multiple agents. So we have magnesium, the NMDA antagonists, calcium channel blockers, antioxidants, NXY059, went through 2 very large trials, activated protein C, which addressed multiple targets, statins with their various effects, anti-inflammatory intervention, neutrophil inhibitory factor, an interesting study I was involved with, and then other immune interventions, and finally albumin, a fairly recent trial. But none of these have been positive. And one reason may be that in these trials, there was very few patients who had successful reperfusion with thrombolysis or thrombectomy. And I think now we see the implementation of reperfusion therapies with, particularly with endovascular thrombectomy. It provides an opportunity to reevaluate neuroprotective therapies, because it may well be if blood flow is not restored, it doesn't matter what you do to protect the ischemic penumbra, ultimately those neurons will fail and die through failure of collateral blood flow. Context of Edaravon is interesting because, as I'll show later, this is unique in showing clinical efficacy in a neurodegenerative condition, amyotrophic lateral sclerosis, and being approved for that in Japan and the US. And at the moment, an oral formulation of that is being looked at under consideration by the FDA. And I'll come back to the data on Edaravon in due course. And if we look at the reasons why neuroprotection trials failed, there are multiple. I went through these in a review I wrote some 14 years ago, where pointing to some of the issues. So many drugs were taken into phase 3 trials too quickly without a clear proof of concept signal in phase 2 trials. And this shows the difficulty of having a surrogate biological marker of response to neuroprotection in phase 2 trials. This is in stark contrast to other clinical areas like cancer, but it's a typical challenge with all drugs that act on the CNS. In many cases, the effect in animal models varied between animal models, and there was a lack of a rigorous evaluation and using controlled methodologies in much of the animal work, so you get selective reporting. In some cases, there was clear efficacy, but only in very short time windows and not in the 3 to 6 hour time window, which was typically where many of the neuroprotective trials recruited. Some of the early trials had very long time windows, such as 12 hours. And interestingly, very few, in fact, none of the trials in the first 20 years used a short time window of 3 hours. And yet we knew from the NINS trial of thrombolysis that early treatment was critical. So the time window for inclusion was probably too long. The second was that most of these trials, vast majority, just use simple CT scan imaging to select patients. Some trials actually entered patients before CT scanning in the very early days. And the problem with that is these trials ended up with stroke mimics, patients with very large, extensive established infarction where there was unlikely salvageable tissue, and hemorrhagic stroke, where the general view is there is little evidence for a salvageable penumbra. In addition to that, in many cases, it wasn't clear that there was good and rapid penetration of drug into the CSF and to the ischemic penumbra. And pharmacokinetic data in terms of optimizing the way drugs were given was often not optimal. Some of the drugs, such as NMDA antagonists, had significant adverse effects with agitation and restlessness, and these proved to be not manageable and very problematic in the context of an acute stroke unit. These are problems, of course, you do not see in anesthetized animal models. And as well as that, we had a lack of structured assessment and training in our standard clinical outcome assessments like NIHSS and the modified Rankin scale, although a lot of work has been done in progressing that in more recent trials. Then finally, many of these studies were underpowered and there were over-optimistic estimations of the treatment effect of, say, 10%, the improving good outcome, whereas I think we now realize a realistic aim would be to achieve a 3 to 5% increase in good functional outcomes. So you need quite large trials to be able to demonstrate that treatment effect. But we do need to do more and look to further improve our interventions, because if we look at large vessel occlusion and the most recent patient meta-analysis, it has a very large treatment effect for this group of patients who generally have a very poor outcome, and that's shown in the plot of modified Rankin scores going from 0, full recovery through to 6, death with degrees of disability in between. And you see a big increase in number of patients who achieve a modified Rankin score of 0, 1, or 2, which is a good recovery, and people are independent in activities of daily living, although modified Rankin scale 2 patients may not be able to do all of their usual previous activities, but they do not need support of other people. But nevertheless, even with that powerful treatment, we are left with over half of patients having a poor outcome with moderate to severe disability or death. So we do want to improve on that in this group of people with a very poor outcome. And there's a nice review by Savitz and colleagues a few years ago describing how now we're establishing reperfusion as a standard treatment for many of our patients. Neuroprotection should be reconsidered because we've got that opportunity, if we can protect the ischemic penumbra until we achieve reperfusion, to salvage more tissue. There are many ongoing studies, and again, this is listed, these are listed in a recent review last year by Alistair Buchan, a colleague of mine in Oxford. And I won't read through all of these, but the key point to note is the majority of these studies are in patients who are undergoing endovascular therapy. And I've indicated that by marking the EVT in red here. And you can see about 2/3 of the ongoing studies are being targeted at patients who've had endovascular therapy. So the current concept is if we go into that group where 80% of patients now with modern practice are having blood flow restored, we should be able to have much more opportunity of seeing a treatment effect. So in that context, if I now move on to Edaravon, this is a free radical scavenger produced by a Japanese company, Mitsubishi, and it is approved in Japan and China and India for use in stroke. There's a good, I won't go through it, demonstration of benefit in animal models of stroke. It's got 3 potential underlying mechanisms of action around inhibiting OH radical induced damage and lipid peroxidation. All of these are steps in the ischemic cascade activation. Japanese guidelines some years ago gave a moderately strong recommendation of a grade B for its use in acute ischemic stroke with the dosing regimen developed there. It's not approved for clinical use in stroke in Western countries, although I'll come back to the position for amyotrophic lateral sclerosis, ALS. And if we take the UK, for example, Edaravon has not been submitted to the regulators or NICE for approval in stroke. So basically the evidence hasn't been looked at. So I think unlike the other neuroprotective drugs I've described that have been studied in stroke, Edaravon is, I think, unique in having efficacy shown in another neurodegenerative condition. And that is in delaying progression of ALS. And it has been licensed in both Japan and the US using a relatively complex intravenous infusion regimen, daily injections, and then drug-free periods. And although the mechanism of action is unclear, it's thought to inhibit the oxidative damage that occurs in neurons, motor neurons, and the neighboring glial at risk for degeneration ALS. And the review article reference at the bottom summarizes the trial data. These are difficult trials to do in ALS. This is not an area I have any experience of. I'm not a general neurologist, I'm a stroke physician. But very clear demonstration of ability to delay the progression of ALS using this Edaravon dosing regimen. And an oral formulation is currently under consideration through the priority review process at the FDA, so that may further increase the use of Edaravon if it's in a much easier to take formulation than having to go into hospital for injections. So if I turn now to the data in stroke, this is the phase 2 trial done in Europe, which was involved a number of countries, including the UK, led by my colleague Markku Kasta in Finland, a really excellent stroke neurologist who pushed forward many areas of stroke care. And the main aim of this was to develop a new dosing regimen than what had been used in Japan that gave more continuous achievement of therapeutic plasma levels over a period of 72 hours using an intravenous bolus and infusion model. A relatively small study with 2 dosing cohorts, 18 patients in each cohort with a 2-to-1 randomization ratio. And the main aim was to understand the pharmacokinetics and test safety, which we did. And a relatively mildly affected stroke population, NIHSS score. Of course, typically average stroke patient will be treating with a reperfusion therapy such as thrombolysis would have an NIHSS of 11 or 12, and for thrombectomy, higher at around 15 or 16. But both doses were well tolerated. We obtained the PK data and were able to demonstrate that the plasma concentrations exceeded the target concentration of 250 to 1,000. You can see even the lower dose was sustained around 500 and the higher dose at 1,500 nanograms per mil. And that wasn't taken forward by the company in Europe for further development. I do not know what the reasons for that are. I suspect it was because the focus of development at that point turned to ALS, and companies often have to focus on where they're going to develop their drug. But there's recently been a meta-analysis of the various randomized controlled trials of Edaravon that have been undertaken in acute ischemic stroke, which nicely summarizes the data. And there is a fair amount of data in 2,000 patients. Most of these studies were undertaken in China and Japan, one in India, and then the phase 2 study I just described was in Europe. And analysis of the quality of these trials shows that they're generally well conducted with a low risk of bias, looking at the various frameworks in terms of randomization, allocation, concealment, blinding of outcome assessment, and completeness of outcome data. So conducted to a good standard. So if we look at those data, we've got data on mortality in 3 studies. So there's 7 studies, we've got incomplete data in some of the important domains. But the largest study showed a significant reduction in mortality with a relative risk ratio of 0.55, which is impressively large if there was no bias in that study. And two smaller studies are consistent with that, but it's driven by that one large study. If we look at the safety aspect, there was we have that in 4 of the studies, safety data reported, and we see no increase or significant difference in the incidence of adverse reactions. More importantly, we want to look at outcomes. So if we look at the 2-week NIHSS score, we see in the 3 studies that examine that a consistent and significant benefit. So with no heterogeneity between the 3 trials. And then if we look at our standard measure of outcome in acute stroke, the modified Rankin score at 3 months, and taking 0 to 2 as a good outcome. Again, overall, Edaravon patients, 27% good outcome compared to 22% in control. So about a 5% difference that's statistically significant. But we would say, relatively small numbers of patients there, and with a 2 to 1, only just under 500 controls, 2 to 1 randomization ratio in those studies overall. But very promising nevertheless, and a 5% improved outcome at 3 months is certainly a highly clinically relevant treatment effect we would be wanting to apply in our clinical practice. I also looked at, did the duration of treatment impact on the 3-month outcome, because there have been 2-week treatment or 1-week treatment, and that didn't show any difference. So we can conclude probably 1 week's treatment is sufficient, and the CAST study even used a shorter period of 72 hours. What is unusual is often data in acute stroke trials have been driven by studies predominantly done in Western countries, Europe and the US and Canada. But that has changed in recent years, with China increasingly contributing to much of the literature. And we will also see that in India. But in this case, most of the data on the drug has come from Asian countries. And this shows that analysis. You've got the 1 European study, and then the 3 Asian studies with the disability outcomes at 3 months. So the data we've got are driven by efficacy in Asian patients, and raises the question, is there possibly a difference in ethnic group in response? Obviously, there are differences in stroke subtype. The FDA in particular always wishes to see some North American data, patient data, when it approves and licenses new drugs. So putting all that together, I think in summary, neuroprotection merits reevaluation as a treatment for acute ischemic stroke, certainly in those patients with large vessel occlusion who are receiving thrombolysis and thrombectomy. I think it seems pretty likely that for you've got to achieve reperfusion to achieve benefit from neuroprotective drugs, at least in those with large vessel occlusion and penumbra. I think it's unclear whether neuroprotective drugs will be effective in strokes due to small vessel occlusion. But it does point to the need to carefully select patients who have salvageable tissue using the developing brain imaging methods we have around looking at perfusion and defining the ischemic core through diffusion, or again, CT perfusion, or even aspects. This can be quite reliable for that. We do have the proof of concept of neuroprotective properties for Edaravon in man, and I think that is important. Okay, it's not, it is a different condition, but it does give encouragement that we're seeing a relevant biological effect that may play out in acute stroke as well. I think we do need further randomized clinical trials of Edaravon using the 1-week regimen, and specifically data in thrombectomy treated in Western populations. But hopefully the company will choose to undertake those and develop those. So we see this as a relevant treatment if trials confirm benefit in the future. Thank you for listening, and I'm very happy, of course, to hear comments and answer questions. Thank you very much.